So next we are going to discuss transplant rejection. In transplant rejection we have four categories: hyperacute, which occur in minutes; acute, which occur in weeks or days; then we have chronic, which takes place in months and years; then we have graft versus host disease. So first is hyperacute. Hyperacute, it takes place during the procedures or within minutes. Then its pathophysiology is due to the preformed recipient antibodies, especially IgG recipient antibodies against donor or the graft, donor or graft antigens. And this type of hypersensitivity is hypersensitivity type 2, and in this on microscopy we have neutrophilic infiltration, which leads to fibrinoid necrosis, ischemia. We can also call it white graft reaction, gross mottling, and then cyanosis, widespread thrombosis of the grafted vessel or the grafted organ. Then we have acute. It takes place within weeks. It has two components, cellular and humoral, and it is also due to hypersensitivity type 2 and type 4. So in the cellular component, which is the most common type of acute transplant rejection, cellular is hypersensitivity type 4. How? So it is due to acute is due to T cells, either CD4 or CD8 T cell react. T cells is reacted or activated against the donor MHC antigens. And it leads to vasculitis of the graft. On microscopy we have dense lymphocytic infiltration. Dense lymphocytic infiltration of vasculitis, and it is type 4 hypersensitivity, and it is preventable by immunosuppressants. And its other component is humoral, which is less more common, and it is same like hyperacute, but it is post transplant, and also it is neutrophilic infiltration, fibrinoid necrosis, and thrombosis, cyanosis, mottling. Rest of the features are all the same, with same as hyperacute sensitivity. Then we have the chronic one. Chronic transplant rejection will take years, and it is due to hypersensitivity 2 and 4. And how 2 and 4? Due to the activation of the T cells, CD4 T cell activated and recipient APC, T cell activated again recipient APC, which presenting donor peptide like allogenic MHC2. When this is activated against recipient, then the recipient T cells release cytokines which proliferate vascular smooth muscle proliferation, which leads to narrowing of the arteries, arteriosclerosis, and then interstitial fibrosis and parenchymal atrophy. It is dominated by arteriosclerosis. Then we have organ specific destruction is when we have lungs. Then the organ specific destruction is bronchiolitis obliterans of the small vessels, small airways. In kidney we have chronic allogenic nephropathy. Then we have cardiac issue, accelerated atherosclerosis, and then we have the vanishing bile duct syndrome. Then we have the last one is graft versus host disease. It has the variable timeline. It is due to the competent graft or donor T cells against host, compromised host, and this type of reaction or rejection leads to organ failure, organ dysfunction, and it occurs especially in the bone marrow and hepatic liver transplants, and because they are rich in lymphocytes, and it is due to the mismatch of human leukocyte antigen, HLA mismatching. And if we have an immunocompromised patient, then we should always irradiate the transfused blood whenever we encounter immunocompromised patient to avoid graft versus host disease. And this graft versus host disease is very much applicable in graft versus leukemic or tumor effect, which is very much helpful in the treatment of leukemia. So this is all about transplant rejections.